questions. So we were all on the same page here.
Kyle, what's my email?
You actually
Come down here. You went over your stuff, right? You went over your stuff?
Yeah, I wanted to meet with you guys next week. Would like to take go over the ones I got wrong, or?
Say that again?
I wanted to meet with you and go over the ones I got wrong.
Yesterday?
Yeah.
You didn't go
The
over
doctor,
it?
no, he gave it to me.
Just come log out of my email.
I looked over the ones I got wrong.
Huh?
I thought you were looking at grades or something.
I didn't know.
All right,
Not to be
okay.
an asshole in the chat.
All right, go ahead, Anita.
What is one side of the pelvis called?
And in nominal.
All right, not the group that was in Anita's class today. So you guys shut up. But the rest of you can answer.
All right, what's one side called?
nominal.
An innominate. Is this a right or a left?
It's a left.
Left.
She told us the truth.
How do you know it's a left?
Look for
The acetabulum is out, and the pubis is forward.
Yep. This surface right here,
So many.
Oscar just said it,
Auriculars.
auricular surface or articular surface, either one, either one. What attaches right here? Sacrum. What type of joint is formed by the sacrum right here? What's the joint called?
Sacroiliac.
Sacroiliac or SI joint? What type of joint is that?
It's a good question.
Non-axial.
Antheo.
Planar. Non-axial.
Syndesmosis.
Syndesmosis.
Oh, yeah.
Is it a planar? We have a planar.
There's a little discrepancy between this. What do you call it?
Anatomy, physiology, people call it planar. I call it amphi.
I call it amphi.
But I wouldn't ask that question only because there is a discrepancy. So that's why she asked the question.
Yeah, I just wanted to see what you guys
Because
said.
it's a little different in some books, just like, is there
movement that occurs there?
do you have anything you had something about the clavicle too, right?
Yes. The SC joint.
Okay, so what is the SC joint?
Sternoclavicular.
And what type of joint is it?
Saddle.
It is a saddle, yes. But there are some books that have something else. It has an upper and a lower joint compartment. It's a saddle. There's a lot of things that occur with that joint. It's a modified saddle actually, because we actually say it's a modified ball and socket, and some people say saddle. So that again, there's some discrepancy in, because there's protraction, retraction, elevation, depression, and rotation. So I wouldn't ask you something that in any book, or you can't find the exact same answer.
There's got to be a consensus.
Yes, and that's your state board too. Your state board's not gonna ask you a question that it may say something different in one book and different than the other. Okay, so let's go on. Because some of you are not doing things, Monica, I've got your test too, so you did okay. And Juan, where's Juan? Juan, you never came into my office to get your test, so if you'd like to get your test, I'll be more than happy to give it to you right now after class if you want. It's up to you guys. Lost my train of thought. I'm thinking of something else. But I asked Anita to come in because this morning she was doing with what we usually do in our class, our side, since she was doing it on her side, but I want to ensure that you guys are doing it also, the ones that are not with me and when I come in and ask questions, okay? So, go on.
Calcaneus?
Calcaneus.
Shut up, you.
Oh, okay.
Excellent. 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 What is this bone?
It's a talus.
Talus. What joint is formed there?
Talus curler. Sorry.
What bones are part of that joint?
The tib and talus.
Good. What motion occurs there?
Plantar and dorsiflexion.
Plantar flexion, dorsiflexion.
Trying to get
If we go distal to that, what is the joint distal?
subtalus.
Subtalar joint. Do we have Hector? Subtalar joint. What motion occurs there?
Inversion, eversion. That was me. It's not Joe.
What about these guys over here? What motion occurs there, Dawn? Huh? Inversion and eversion.
Inversion and eversion.
What is the name of that joint? What is the name of that joint? Subtalar.
Subtalar
Okay,
joint.
now put a pen between. Does anybody have a pencil? Or, here. Between you guys, over here. You guys, shut up. Except for Brian back there, you can join this crew here because these people aren't, they're bad. So you.
I'm trying to get into my email.
What is this joint? Mid-tarsal joint.
Ari,
Yeah.
what occurs there?
Plantar flexion,
Ari,
pronation is
Better.
pronation and supination. Okay, Ari, what is pronation?
pronation is when your foot is turned.
What movements make up the act of pronation?
Good question.
Ari,
Is it inversion?
don't ask me ever, is it? Because I will tell you.
Come on, name it and claim it. Full send. Just say it.
What will I tell you if you ask me?
I
is it?
don't know. Is it?
Just like you told me.
Say, look it up and see if you're right. You're gonna hide it from a student and put it in a book.
Oh, wait. Yeah, I missed one.
Dave,
Check my email.
Who can help?
Dave,
A deduction? A deduction.
What is it? Plantar flexion, abduction, and inversion?
I'm all confused now.
What? What are we talking about?
What makes up pronation?
What makes up pronation?
Yeah.
What'd you say, Donnie?
Dorsiflexion, inversion, and adduction.
Dorsiflexion. What's the next one? AB or AD? AD. No. Ashka.
Abduction and eversion.
Abduction and eversion. Debbie. Deb-E. D-A-B-E. If you remember that one, you'll remember the other one. Pad-I.
Spatty.
Abby and Pat-I.
Debbie.
All right,
And
what?
Andrew, don't make fun of my mnemonics here. I see you looking at him and looking. I see that. I don't appreciate that, Andrew. Looking at Chris all the time, making fun of me. I see it. Remember, I know more than you, a little bit.
A little.
Sustentaculum tali.
Oh, very good. I missed that one.
Okay.
Is the sustentaculum tali on the medial or lateral side? Who says medial? Raise your hand. Who says lateral?
Who says they don't know where it
Who
is?
says they have no clue where that structure is?
Go ahead, go show it. Sustentaculum tali. Sustentaculum tali.
You know where it is?
It's a shelf.
The shelf
Shelf for the talus.
He's fixing the bed.
Alright, I'm gonna contact Vegas real quick.
He's gonna type all the questions today and he's gonna email them after that.
What would be alternation?
Which one?
Latin for shelf. It's a shelf for the talus.
Well, you have the foot in hand. Oh, come down here, please, because I don't want to say it.
What are we
And
eating?
don't look at these guys,
What's wrong with these guys?
because we went over stuff, and you know the answers, and if you don't know the answers, then you know what I said.
Go look it up.
It's medial. It's on the medial side of the foot.
What's this?
Told me not to say.
What's this?
Is this sesamoid bone?
Get out of here. Who the heck? What's this?
It's because Dave doesn't know.
That's a femur, right?
Yeah.
Andrew,
She's pointing to the thing on the bottom of the test.
what is it? First metatarsal. What type of joint is formed at this bone's proximal articulation?
You told me I'm not allowed to say it.
Andrew, you say planar? I say you're right. Did you hear what he said?
Yes.
Plainer.
Planar, gliding, right? Okay. What's this? Brian,
That's distal tarsophalangeal.
distal,
Tarsophalangeal.
you say distal what?
Tarsophalangeal.
Tarsophalangeal. Where the heck are you going to school? Tarsophalangeal.
I have it in my head. It's distal
Distal what? Begins with a P.
phalanx.
No, I didn't ask for the joint. I just asked for the bone.
Distal phalanx.
Distal phalanx. Okay. What type of joint is formed at this bone's proximal articulation? Yes, you do.
Oh, come on.
Yes, you do.
Saddle.
You told me the name of the joint. What is the name of the joint? What's this bone and that bone? All you have to do is look at the two bones and then name
What
it.
do they do?
What's this one called? The interphalanx, right? And this is the distal phalanx. So what is this joint called? If you got this on the test next week, you'd have to know it, right?
Right.
So I'm asking you, and maybe I'll put this on the test and I'll say this is just special for Brian. All right, so what is that called then? The DIP, the distal interphalangeal joint. Having said that, it's no different than this,
Yeah.
right? Who's that guy? So what type of joint is that? What type?
Come on.
What type of joint is
What
this?
motion occurs there?
How many motions can I do?
I know everyone's just...
Huh? Gliding?
Flexion
Flexion
extension.
extension.
Flexion extension. So what type of joint does that? Hinge, right? Okay. So that's for Brian. I'm going to put it on there.
Just for Brian.
For Brian. All right. Go ahead.
Not any of my running backs.
Not from any of his running backs. All of them.
Right or left?
Orange.
Right scapula.
Who says right? Raise your hand. Who says left?
Please no one says that.
Why? How do you know it's right?
Because the glenoid's facing out.
The spine and the glenoid fossa.
Yep. Glenoid fossa right here. What's this? Yep. What's this? Medial or vertebral border. What's this? Lateral border. What's this? Spine. What's in here?
Supraspinous fossa.
Good. What's this? And this? What joint is formed right here?
With the clavicle.
With the clavicle. What kind of joint is that?
And roll. And roll.
What kind of joint? What do you say? Gliding.
Gliding. Gliding joint.
But if the question were phrased, what type of joint or joints are formed by this bone's lateral articulation.
AC.
All right, no, what type or types of joint are formed at this bone's lateral articulation? What am I asking? What's attaching to this bone laterally? So having said that, Dan,
GHK,
what type of joints?
so it's gonna be a ball and socket for the GH, and then it's gonna be a gliding for the AC.
Excellent. Do you guys understand that?
Yeah, Dan.
Oh,
What is this right here?
Awesome.
Ever get that? Glenoid fossa?
and what are the little things above and below the glenoid? What, supraglenoid tubercle and? Cindy, what attaches to the supraglenoid tubercle? The what?
Short-handed biceps.
The long head of the biceps.
It has to go through the bicycle group.
Okay, what's that little divot? What's that little divot right here?
Oh, it's, where these,
Ah!
Scapular notch? Suprascapular notch?
Suprascapular notch.
Is there a scapular notch elsewhere?
No.
No,
So do we have to specify that supra?
yes.
Okay.
That's what
If
it's
you,
called.
yeah, if you said scapular notch, I wouldn't take it. But that's important, because as we will see today, there's a ligament that goes over there. It actually forms a kind of foramen.
it's both a ligament and the
And it actually forms an anatomical foramen. Okay, let's move on. What are you talking about, you two? It's enough.
Nothing important.
All right.
Everyone see it?
He yawns, you talk.
What part of the spine is it from?
That looks like an axis from here.
C2.
I see a dent. I see the dens.
I see a
Looks
dent.
like
That's
an
why I'm trying to hold it up. Everyone see it?
axis.
C2, yeah.
Yeah,
Okay.
C2 axis.
What does this structure articulate with inferiorly?
Superior articulation.
Where?
Superior
What?
articular fascia.
The whole C3?
Superior articular fascia.
All right, you don't have to show how smart you are. I have heard nothing here. It's attaching to the superior articulating facet of C3. That's what you would have to say on the practical exam.
Yes. What type of bone is this? Irregular.
Well, what shape?
What shape?
What shape?
Irregular.
How do you differentiate between, and show it, a thoracic and a lumbar vertebra, other than one's bigger than the other? What if I put a big thoracic vertebra on? You wouldn't be able to tell the difference. How do you differentiate? You guys understand that? Do you
It's hard to
know?
show you guys with this cable running through it, but
You know. We have two articulating surfaces for the ribs. Costovertebral and costotransverse, which are, that just means one is on the transverse process and one is on the body. Okay, they are the articulating surfaces for the ribs.
For the
Yes.
practical, do we have to name the specific ones or
No.
just the cost of the sets?
it's also a good way to identify the structure if it's laying on the table. That's one way you can identify thoracic from lumbar, is you will see those articulating surfaces on the thoracic, not on the lumbar.
What canal goes through the occipital condyles?
You're stumbling.
Erie,
That's so oddly.
Erie Canal,
The Erie Canal.
there's a foramen.
The Panama Canal.
Foramen magnum.
Look it up.
How does it
it up. What goes into the foramen magnum? Spinal cord. What's the medulla an extension of?
Brainstem.
Spinal cord, right? Spinal cord, medulla. What bones make up the acetabulum? Jade. What bones make up the acetabulum? Chris?
Oh, all the,
There's another Chris. Where's the other Chris?
right. Right.
Oh, that's right, the Chris with the
Oh, Christmas.
Christmas.
Rich is pretty quiet back there. Let's ask him.
Rich? No, Rich knows. Did you know Chris?
Oh, yeah.
Okay.
The acetabulum,
Yeah.
femur, and the hip.
Femur? Get.
The
I said, what
acetabulum-
bones
oh,
make up the acetabulum?
Not the joint.
Oh, the actual acetabulum.
Yes.
Well, the part of the innominate, I'd say probably the ischium, pubis, and the ilium, all three combined.
Correct. Correct. The ischium, the ilium, and the pubis. Correct. Yeah. We don't have a calvarium. What's the name of the suture in the back of the head? Chris? Lambdoidal? What bones make up that suture?
Occipital, oral, and, parietal.
Did he say parietal, temporal?
Yeah.
Yeah.
Okay, what goes through that little hole in the cervical spine? Dawny! What goes through that little hole that she's pointing to?
Below.
Which one you pointing to?
This one, the little
Yeah,
one.
yeah. Chris? Vertebral artery. Yeah. What does the vertebral artery join with superiorly? Andrew? Basal artery. Where does it come from inferiorly? Devin. You've been dying to answer.
Not this, all right.
Not that one. Only the ones I know.
The brachiocephalic subclavian.
So subclavian, right?
Yeah, subclavian. See?
What is the brachial plexus? What are the chords of the brachial plexus? They're named according to their proximity to a specific structure. The chords of the brachial plexus. So they are lateral to something, they are posterior to something, and they are medial to something, some specific vessel. What is that vessel called? Now, not you. The axillary artery. Where does the brachial plexus lie? Between what structures?
C5, T1.
What structures?
Well, the,
Anatomical?
First rib.
Clavicle and first rib. You got anything else there?
That's all I got, really.
All right. That's good. Was that okay for you?
Is that helpful?
Yes.
All right, you have today at 1 o'clock to work from 1 to 3 or whatever time you want to look at bones in the lab, in our labs. Okay, so whatever labs you were in before you're gonna be in. I couldn't put you up here because they wanted 2 instructors to be with you. And we don't have 2 instructors. Tuesday we will. Okay, so we are going to start muscles on Wednesday and Thursday of next week. So Monday and Tuesday, we'll still do bones, and we'll make sure that you know everything, and we'll come around and we'll ask you all these questions, and we expect you to know all the answers. On Wednesday and Thursday, we'll probably give you maybe 10 muscles. We'll start with some cervical muscles, longus coli, splenius cervicis, and then we'll go from there to like the trapezius, the SCM, the levator scapulae, maybe the rhomboids. I don't know how far we'll go. We'll see how far we can go. And then on Tuesday of next week, you will have a muscle quiz in here. Okay? Let me tell you something. The muscle quizzes can ask you anything. I will ask you muscles. I will ask you origins, insertions, actions, and innervation of muscles. But I could also ask you something like, tell me 2 muscles that you know that are innervated by the lateral cord of the brachial plexus. Something like that. Okay? So, and as we get deeper into this and you know more muscles, I can ask you more questions and more specific disorders. So right now you don't know much, right? I mean, not that you don't know much, but we don't know many disorders. Like we know the capsular pattern of the shoulder, of the glenohumeral joint. And can somebody tell me the capsular pattern of the glenohumeral joint? Anybody else? Anybody else?
I'm probably gonna butcher it.
I'm gonna put you guys in the back of the room. Anybody else? Tell me the capsular pattern. You're Brian, right?
Yeah.
I knew you were Brian. Brian, what's the capsular pattern of the glenohumeral joint?
Pattern,
I don't know.
flexion, extension.
Flexion, extension. What's capsular pattern mean to you?
Wait.
Make sure you're writing this down if you don't know it.
Well, we talked about it already. What's,
No.
Marissa? My ears are old, I can't hear.
Can you say it again?
External rotation is, greater, when it's greater than abduction, which is when it's greater than internal rotation.
Absolutely. So
Yep.
which muscles are most limited? Which muscles need to be stretched? The internal rotators or the external rotators? External rotators? The internal rotators.
Excellence is greater than the six of the water.
You following?
Yeah, so where is that patient mostly limited?
So they're limited most in external rotation. So if they're limited most in external rotation, in what position will they be? Mostly internally rotated, which means that the internal rotators are shorter. So they're the shortest. The longest would be the external rotators. Okay? And that's a real culprit for somebody who has adhesive capsulitis. Adhesive capsulitis is a frozen shoulder, and a frozen shoulder is denoted by that capsular pattern. In that capsular pattern, you will see that you will have to go in, get the lat and the trap out of the way, and try to go in and find that subscap, because that subscap is on the subscapular fossa. How do we get there? Difficult.
You get it.
It's up under the arm.
Yeah, so you get somebody supine, abduct their shoulder, get the lat and the trap out of the way, go in and feel. Okay? You're looking at me like I have 2 heads. You understand? You got it? Okay. All right, let's begin. Thank you very much.
You got it. I'll take these back down.
Okay, thank you.
You
Okay.
need anything else?
No, thank you. We're gonna talk about the rotator cuff today. We're gonna talk about the shoulder. Yes.
So with capsular patterns, it's talking about which planes of motion have more degrees of freedom than the ones, so for
No,
example.
capsular pattern shows capsular restrictions. Every joint capsule has someplace that it favors going. So a capsular pattern means that it's going to be restricted in specific motions. So if you really have to look to see if there's a capsular problem, it usually follows a capsular pattern. Because how do we know that it's a capsule we have to deal with rather than a tight muscle? So we have to identify it by a capsular pattern. Because I could have a decrease or a loss of dorsiflexion in supine, and that could be secondary to gastroc tightness, or it could be the capsular pattern of the ankle. So do I need to mobilize the ankle joint, or do I need to stretch the gastrocnemius? So I need to know. Yeah.
So when you say one thing is greater than another,
It's limited greater.
The limitation is greater.
Yes. External rotation is limited greater than abduction, which is limited greater than internal rotation. That's what it means.
Meaning internal rotation is the least limited.
Correct. Correct. And that'll make a lot more sense when we start measuring, because you'll see that your external rotation should be at least 90 degrees, could be limited secondary to a lot of things. Could be limited because you have an anterior humerus, anterior glide of the humerus, could be limited because your internal rotators are tight, et cetera, et cetera. Could be limited because you have a capsule problem. So we have to find out which one is providing the limitation in order to know what to do, right? So I gave you that example about the gastroc. If we needed to stretch the gastroc, what can we do? We could do a heel cord stretch, right? But if we needed to do a joint mobilization for the talocrural joint, which way we would need to mobilize it to increase dorsiflexion? Everybody understand what I just said?
Yeah.
I talk fast sometimes,
Posterior.
but
Posterior.
my question to you, my question to all of you, I don't mean to ignore you. My question to all of you is, if that gastroc weren't tight, and it were truly an ankle capsule that was causing the restriction, in what way would I need to mobilize that joint to improve dorsiflexion? So, what do I have to know? Dawn, what do I have to know in order to know how I need to mobilize a joint? What do I need to know? I need to know the concave convex rule, right? So, can you tell me what that is? If the movable bone is concave, so we have two bones, one's stationary, one's movable, right? If the movable bone is concave, how do we move it? Same direction we want the bone to go, right? We want the joint to move. And if it's convex, we go in the opposite. So what do we have to know for this glide, these arthrokinematics? We have to know, is the glide in the same direction, in an anterior direction, or is it in a posterior direction? So we have a stationary bone and we have a movable bone. What are we concerned about? The movable bone. So what are we moving when we move the talocrural joint? What bone are we moving? The talus. And what shape is the top of the talus? Convex. You guys know, because I think sometimes some of you just may not know the difference between convex and concave. Concave, think of a cave, you go into it. So this is a concave surface, a convex surface is a bump. Okay? So what shape is the top of the talus? It's convex. So according to this rule, which way would I have to move it? I would have to glide in the opposite direction. So I would have to do a posterior glide. All right? That kind of question can be on the practical next week. It can. I could ask you something about a finger, but you got the bone right in front of you, so you should be able to know, because you're looking at the bone. All right, just remember that, yeah.
You want the ankle to go into dorsiflexion. And we want to know which way to glide it. You say posteriorly, it's a convex surface. So the foot is going up, therefore it's going down. Is it more like inferiorly, or same idea, posterior?
No.
inferior?
No. Anterior and posterior is just this. So I take the foot and I would just do this. If I was doing inferiorly, that would be a distraction. I would be pulling it away,
Oh, okay.
okay, rather than pushing it. You get it?
Yeah.
Okay.
So the foot is going up, so we want to mobilize
Correct.
it down. Okay.
Correct. Okay, so what do we know about this glenohumeral joint, or the shoulder? We have this shallow, it's very shallow, the the glenoid itself is much more shallow than the acetabulum, is it not? Just from what we've been examining in class, looking at bones, we see that the acetabulum is pretty deep. So we have that head pretty secure. And by the way, the rotator cuff muscles of the shoulder are pretty much equivalent to the deep external rotators of the hip. And sometimes some people call those deep external rotators of the hip the rotator cuff of the hip. So a lot of people forget how important these muscles are. But the glenohumeral joint is a very shallow socket. So there is something there to help hold the head of the humerus in the socket, and that's a fibrocartilage known as the labrum. And the labrum surrounds the glenoid. Sometimes you can get a tear of that labrum. I'm sure that you've heard people that have had that. Or they develop some instability, or they hear, when they move their arm, they hear a clunk or something like that. Or they have multi-directional instability. So this glenoid labrum would help deepen the socket. But there's also really the importance of the rotator cuff muscles. The rotator cuff muscles are known as the sits muscles. And the sits muscles, we talked sits, S-I-T-S. We said this, didn't we? Sits, no? Subscapularis, infraspinatus, teres minor. What's the last one?
Subscapular, no,
It's supraspinatus.
Supraspinatus. So supraspinatus. Okay, supraspinatus, infraspinatus, teres minor, and subscapularis. Which is the most common one, commonly injured?
Teres minor.
Supraspinatus. Supraspinatus is in a very avascular zone, and it actually attaches right under the subacromial fossa into the greater tubercle. Very susceptible to, very vulnerable to damage, along with the long head of the biceps, which is very intimate with the shoulder capsule itself. So the rotator cuff muscles stabilize the bone in the socket, and the supraspinatus also is really important so they keep it centered, and the supraspinatus is also very important for depressing or counteracting, all the muscles are, but more the supraspinatus than all of them, but they all are, counteracting the pull of the deltoid muscle. The deltoid muscle, if the rotator cuff muscles aren't strong enough, the deltoid muscle will just cause the superior migration of the humerus into the top, the acromion, cause problems. So the rotator cuff is constantly working together with the deltoid to keep the head of the humerus in the socket. So the cuff muscles are responsible for that. Okay. SC joint. It's the only attachment to the trunk. So the SC joint is the only thing that provides the shoulder attachment to the trunk. And it has this fibrocartilaginous disc. This fibrocartilaginous disc has a superior and an inferior compartment. And this fibrocartilaginous disc is also, if you fell on an outstretched hand, it prevents the clavicle from going into the sternum. So the articulate discs actually attach the medial clavicle to the costal cartilage, and there is a ligament there known as the costoclavicular ligament, costoclavicular. So it attaches the first rib, which is the costo, to the medial side of the clavicle. Okay? You could also see that we have these interclavicular ligament that attaches the clavicle to clavicle. We see the disc, we see a superior and inferior joint compartment with the disc, and we see the sternoclavicular ligament, which goes from the sternum to the clavicle. Okay? So this is the SC joint. SC joint isn't injured as much as the AC joint. A couple of you people in here have AC joint injuries. picture of the AC joint, but the ligaments associated with the AC joint. These AC ligament as well as the coracoclavicular ligament both act to stabilize the AC joint. So they're really both important in the AC joint. And if you have a fall that's forceful enough, you get a tear of the coracoclavicular ligaments also. Okay? So if we look at this picture, we can see the AC joint, we can see the acromion, we can see the coracoclavicular ligament. We have a model of it in class, which we'll look at on Monday and Tuesday. Of course, I could put that model on, just for you to name the ligament. And if we look, and we see a lateral and a medial ligament, one's the trapezoid, one's the conoid, and the conoid attaches to that conoid tubercle. And the conoid is more like fan-shaped, difficult to see. And trapezoid is more trapezoidal in nature. And they attach the clavicle to the scapula. So most medial, you will see the conoid ligament. Okay, sometimes it's difficult to differentiate, but if you see a picture, most medial is the conoid and most lateral is the trapezoid. And together they prevent movement of the scapula, and individually they help with scapular rotation. They help limit scapular rotation. And any ligaments assist, prevent, or provide movement. Okay, so these two ligaments are really important for the AC joint. You could have an AC joint tear, you could have the AC ligament, you could have a the coracoclavicular ligament tear. Usually requires some kind of surgical intervention. You had an AC separation or tear?
I had a separation grade 3.
Grade 3, okay. What did you do for it?
Not a thing.
Did you put any, did you have a?
Sling, so I was sling for about 2-3 weeks.
You did that by yourself? Or?
Yeah.
So you didn't see anybody?
I went to the hospital in Pennsylvania, they didn't tell me much, put me in a sling and that was it really.
And then you did whatever you wanted to
You
do?
did, yeah.
Okay, so the coracoclavicular ligament, here it is here. You can see the conoid and the trapezoid. And remember we said that coracoclavicular means that it's coming from the coracoid process and going to the clavicle, right? Okay. And specifically that conoid ligament is medial and attaches on the underside for posterior to the conoid tubercle. The coracoacromial ligament is really not part of this process. It does provide a protective arch to the humeral head, and what its main reason is to prevent superior migration of the humeral head. Okay. The glenohumeral ligaments are important because they go from the labrum, and they reinforce the capsule from the anterior, middle, and posterior and inferior surface. So they attach to the tubercle and the anatomical neck of the humerus. What's important, and we will see it in the picture that you'll see right here a little bit later, and even another slide or two, is that we have another ligament known as the transverse ligament, and that ligament actually is protective and stabilizes the long head of the biceps. So here's that transverse ligament from the greater tubercle to the lesser tubercle. You can see it right here. Okay, and this whole thing then would be known as the bicipital or the intertubercular groove, right? We're okay with that? Intertubercular groove, bicipital groove, long head of the biceps goes through there. There's also the lateral lip and the medial lip of the bicipital groove, and when we talk about that, we'll talk about attachments for the latissimus dorsi and the pec major, which are the two large, huge muscles that if you look at somebody from a sagittal view, a cadaver dissection, you could see how that anterior, posterior part of the body are delineated by these two large muscles. Okay. There's also, remember I said to you, what is the scapular notch or suprascapular notch? Why is it important? Well, I'll tell you. Because there's a ligament there. It's known as the superior lateral scapular ligament, and there's also, some people call it the scapular transverse ligament. So you may see, I won't test you on this, but you may see both names for it. Okay, why is it important though? I tell you it's important because it makes its own, you can see the ligament, where's the ligament? Right here. Can you see the ligament right here? So it's a tiny little ligament and it makes a hole. And that hole, anytime we see holes, we say foramens, right? So it makes an anatomical, for lack of a better word, foramen through which the suprascapular nerve travels. So right on that suprascapular, or on top of that suprascapular notch, you have a nerve. So for those of you, and I think I have this on later on in a slide also, but for those of you who carry backpacks and things like that on one side and then start maybe getting some tingling, what area would you get tingling in? Because you would have to know the dermatomal representation of the suprascapular nerve.
Fingers, forearm.
Fingers?
Shoulder, lateral arm,
Now we're guessing.
shoulder, lateral.
Suprascapular nerve is associated with what root levels? C5 and 6, right? So our tingling, our numbness would be
So
in here.
deltoid, teres.
Yeah, well, upper arm. And I'll show you a picture later on of something that you see pretty much commonly. All right, common glenohumeral problems. Rotator cuff tendinitis. You could have a tendinitis of any rotator cuff. Most commonly, you see it in the supraspinatus. Rotator cuff tears, again, do an MRI to look at these things. If you do an x-ray, it's showing you bone. Do an MRI, it'll show you soft tissue. Okay, so we can't see on x-ray if somebody's got a tear. Bicipital tendinitis, or a rupture of the bicipital tendon. Usually it happens with the long head of the biceps. Long head of the biceps, you guys know, originates from the supraglenoid tubercle. Short head of the biceps originates from the coracoid process. Where does it fall? It falls in the arm, right? Usually falls down from around here to here. I'll show you a picture of it also. And sometimes they say there's a Popeye's deformity. Popeye had those big arms down here. I don't know why they said that, but they call it a Popeye deformity because it unrolls and just drops. Yeah,
That's what I was gonna ask.
that was the question?
No, if that was the thought.
See, I anticipated it. Okay. I had to keep on my toes with these guys. They ask me a lot of questions.
I'm under 3.
Okay.
So
Labral tears
That's
or glenohumeral dislocation, subluxation. You could have a dislocation, subluxation. Mechanism of injury, or I should say most glenohumeral dislocations are anterior. Anterior dislocations. The difference between a subluxation and a dislocation is ligaments are not preserved, are preserved with subluxations, and usually are not with dislocations. Okay, you could have an anterior dislocation with a labral tear. You could have a Bankart lesion and different things that we'll talk about, or a Hill-Sachs lesion, which I'm sure you've heard of, because there's a lot of ball players that have those lesions. Could have a frozen shoulder. Frozen shoulder is known as adhesive capsulitis. Okay, adhesive capsulitis. You can have arthritis. Does anybody know the difference between rheumatoid arthritis and osteoarthritis? There's lots of different types of arthritises. As I did my dissertation, I found out at that time there were hundreds of different types of arthritises, which I really didn't know about. But there is psoriatic arthritis, there's all different types of arthritis. But the most common ones that we'll be dealing with is an osteoarthritis and a rheumatoid arthritis. Does anybody know the difference? Chris?
Rheumatoid arthritis is an autoimmune disease.
Rheumatoid arthritis is autoimmune?
Rheumatoid arthritis.
Rheumatoid,
Yeah, autoimmune.
autoimmune.
Yes. Whereas osteoarthritis is general breakdown of your cartilage over time, degenerative wear and tear.
Okay, they used to say wear and tear. They don't say so much anymore. But they don't, because they just say, just because you get old, you get arthritis. I don't have arthritis anywhere. I happen to have arthritis in my knee, but that was secondary to traumatic incident and a compound femoral fracture. But otherwise, I don't have arthritis. But yet, I bet somebody in here does, right? You do. Okay.
You had a compound femoral
Face, see?
fracture?
What was your comment?
Oh, yeah, pretty much the same exact.
Pretty much the same thing, okay. So, rheumatoid arthritis is systemic. Systemic meaning it affects everything, and not just one joint. It affects all joints. It's systemic, it's autoimmune, and it's a disease of the synovium, as opposed to osteoarthritis, which is a disease of the cartilage. Okay? So can you have both? Sure.
Yep.
When we talk about the hands, we really talk about the differences because you develop nodes or nodules associated with this. I have some, just because I was a very manual therapist. So I have some breakdown of the joint here. But that's just secondary to misuse for me. Not so much because I'm old. All right, Chris?
Well, no, I actually didn't say age
I'm
related.
not, believe me.
Yeah, wear and tear
I'm
can be
kidding.
anything.
I'm kidding, I'm kidding.
Did you say you had a compound femoral fracture?
Yeah.
That's wild.
I had a compound femoral fracture mid-shaft, motorcycle accident.
Oh, yeah. Oh, that's
I was in a Thomas splint with a Steinman pin for 10 weeks. I was in the hospital for 3 months, and I was head trauma. And I was in a coma for a week.
holy shit.
Yeah.
That's hardcore.
And they didn't have any place to put me because I went to a local hospital and they put me in the cardiac wing, and when I started to wake up, they said, "Oh, the motorcycle girl's waking up." It's the first time I was ever on a motorcycle.
Really?
I would like to say it was the last, but it wasn't. I
Alright.
should have learned. But it was the first time. But it's a terrible thing. Don't ride motorcycles. I could preach now,
Yeah.
but anyway. And an impingement syndrome. There's all kinds of impingements. Most commonly, we're going to talk about the shoulder having a subacromial impingement. Subacromial, under the acromium, there's a space. That space should be there for movement to occur. Sometimes you get a bursitis and you get an inflammation, and the bursa decreases the space. Sometimes you have a hooked acromion, or you have a different shaped acromion that affects the space that it travels through. Sometimes you have a tendinitis, and then you wind up with an impingement. So there's a lot of reasons why you could get an impingement. The rotator cuff problem, we talked about the rotator cuff, the sits muscles, supraspinatus, infraspinatus, teres minor, subscapularis. You want to know what those muscles do? Supraspinatus initiates abduction, and these cuff muscles will stabilize the head and the cuff. Okay, but initiates abduction.
Super.
Teres minor is a shoulder external rotator.
Some adduction.
Oh, I forgot the I. The infraspinatus is an external rotator, and the subscapularis is your prime internal rotator.
Wasn't the teres minor just shoulder adduction as well?
Yeah, horizontal abduction and abduction. External rotation, sorry. Okay.
Where's it?
So here we have that, remember I said there's a bursa? What's a bursa? It's a fluid-filled sac, right? Remember we talked about that? Fluid-filled sac, a bursa? And if you try to look at it on the cadaver dissection, it doesn't look like much because it's not full anymore. But it separates, it causes separation between the acromion and the humerus. And we have the rotator cuff as well as the humerus. And here's the bursa separating. And here's the head of the tendon of the supraspinatus. So you can imagine, you get bursitis, decreases the space, pinches this, right? So then you wind up with pain. Subacromial impingement.
It's not anatomical, is it?
What, the
The
bursa?
bursa?
What do you mean it's not anatomical?
Like, is it there or does it develop?
Oh, no, it's there.
It's there, okay.
Yeah, it's there.
What is the function of those?
Bursa separate, usually they're for protective in nature for tendons, so they cause a separation so that the tendon doesn't ride directly over a bone.
Okay, so
Rotator cuff tears, they're common also. Again, supraspinatus, probably the most common. And here are some types of tears. The only thing I want you to remember for this, because everybody got their own protocols, I want you to know that a small tear is less than 3 millimeters. And usually, they may do a mini open surgery with this or an arthroscopic surgery. Yeah.
Do we do a grade of like grade 1 to 3 for this one?
I'm sorry?
Is there a grade for this one, like grade 1, 2, or 3?
Is there a grade for it?
Yeah, for rotator cuff tears.
Well, this is what we're talking about. These are the type of grade 1, 2, 3, or small tears, big, large tears, and
So
massive
grade 1
tears.
is small.
That's usually what they say. So it's a small tear, a large tear, a massive tear. So if it's a smaller tear, they may do a scopes, they put some portals in or some holes in, and they put a camera in, and they go and put an instrument in, and they repair it. A large tear is 3 to 5 centimeters, and they usually do an open. They usually do exploratory with that, and a massive tear they have to open. So they do greater than 5 centimeters. Sometimes they take a transposition, or they take one tendon, they transpose it someplace else, and then they tack it down with sutures. They reinforce it. Okay. We're not going to spend a lot of time on this. I just want to talk to you about if you had, you're seeing that, if you look at the mini and you look at the open, you're saying that isometrics is done for a long period of time. Why do you think there's not isotonic or isokinetic exercises done if you have a tear and a repair of a rotator cuff? Why wouldn't you think there'd be, go ahead, Chris?
Re-tear by
You like the range of motion?
lengthening and shortening the muscle.
Yeah, contracting.
Because if you're gonna do an isotonic or isokinetic, you're gonna ask for the muscle to contract and to pull on the tendon, and which may disrupt the tear. Yeah. So you wanna be careful. All right, so don't worry about this, because I just put this in to show you an example of what a protocol might look like. I'm not gonna ask you questions about what would you do at 6 weeks, what would you do at 3 weeks. Okay? So avoid functional activities. What does it mean by a functional activity? Yeah, lifting your arm up, combing your hair, reaching into things, carrying things, all that kind of stuff. And dynamic strengthening. Dynamic strengthening would be more, you see a lot of dynamic strengthening in rehab where they do weight-bearing exercises. So weight-bearing through a BOSU or something like that, or getting down on all fours, or rocking, or, doing one arm at a time, or quadruped PNF, that type of stuff. Okay. So let's not look at this for now, because I just put that in there just because we can come back to that, but not right now. All right, so a normal cuff, and you can see a torn supraspinatus tendon. So, I remember, I don't know if I even said, but the supraspinatus attaches to the greater tubercle. Did I say that? Attaches to the greater tubercle. And so since I tell you now that it attaches to the greater tubercle, does it make any sense to you that during passive range of motion and abduction, we have to do something with the shoulder? What do we have to do with the shoulder when we perform passive range of motion in abduction? What do we have to do? Externally rotate. And why do we externally rotate? We clear the greater troch from the acromion, right? So what if we didn't? You keep hitting the supraspinatus, and the infraspinatus is below that. So that should make more sense to you now why we do that, right? All right. I do have also, and I think I might show it. I don't know where maybe I'll show it here, maybe I'll show it in lab. I think it might be easier to show it here because I have you all together. A whole cadaver dissection of a shoulder so that you could see the cuff itself. There's a lot of redundancy in the cuff, meaning that the cuff, there's a lot of room in that cuff. You have to have a lot of room in the cuff so that you could have all these motions. And then you can clearly see that the long head of the biceps is very intimate with the joint capsule itself. So this also can be impinged beneath the acromion, and it could be sheared within that spinal, bicipital groove. So you could have shearing over time of any tendon with overuse, right? If you had, a lot of people come in to see you, And maybe they've wound up with big problems after they had maybe a subacromial impingement. So if you have a subacromial impingement, what do? It hurts. So what do? Especially if it's a subacromial impingement, it's going to hurt with overhead activities. So what are you going to do? You're going to avoid overhead activities. Or you're going to avoid these type of activities. Or you're going to stop fastening your bra. You know, ladies, well, I shouldn't say that, but, some women still put their hands behind their back to fasten their bras. You guys don't know how lucky you are. But some women put it here and then swing it around, and, they do it because maybe they lose range of motion, or maybe because they have pain in their shoulder, and they have to do it this way. Or as you get older and as your posture changes, you can get shearing of this tendon very easily because of the way you stand. So you have to do a lot of posture. Are you growing something there? You are? Oh, okay. You have to do a lot of I never saw that before. But you have to do a lot of postural corrective exercises with somebody because every time they lift their arm, they're going to smack on their tendon. Right? So some of the things that we do are, we evaluate someone's posture, yeah.
What about passive range of motion? If someone, you wouldn't want them reaching overhead on their own, but to help them so they don't lose their range of motion in therapy.
Well, I'm glad you asked that question.
Why do I ask it?
I said, I'm glad you asked that
Oh,
question.
glad.
Because too many people, and I really mean this, don't even look at the scapulothoracic joint. They don't even look to see what's happened with the scapulothoracic joint. If you don't have full scapular upward rotation, then you're creating an impingement. How are you creating an impingement? You're not getting, the movement is not occurring at the scapulothoracic joint, but it's occurring at the glenohumeral joint. So you're overusing and stretching those muscles, and you can develop more of an impingement because the mechanics are just not appropriate. Okay, when you lift your arm, when this is going a little bit further than we need to go, but we talked about the fact you have it's about 3 inches away of the spine from the scapula from the spine. We have an inferior angle, the scapula sits at T2 to 7, right? We have an upward rotation. When we do an upward rotation of the scapula, the inferior angle should really go into the axillary border. Not only that, but when you do full elevation or abduction, the acromion should sit at the level of C7. People don't even look at that. They don't even look at that. Or they don't look at the fact that the scapula is internally rotated or externally rotated. So an internal rotation of the scapula may be secondary to external rotators of the humerus that aren't strong enough or that are too tight. But that's a little bit more advanced. We'll talk. But that's a good question. It's a good question because you always have to look at the scapulothoracic joint. Even just to say if somebody's internally or externally rotated, you can't make that determination just by looking at somebody until you've looked at the scapula. And there's new research that just came out that's talking about the not only the rotator cuff itself being the culprit, or not only its impingements or the scapula, but actually where the glenoid is facing. Because if the scapula needs to sit about 30 degrees in a coronal view. So the scapula doesn't sit right here, it sits like this. And that sitting this way requires us to have another plane that we talk about. We not only talk about the sagittal plane and the coronal plane, but we talk about the scaptional plane. And that's formed from where the scapula sits on the ribs. And that can change, and then the glenoid changes, and then it could appear that you have an internally or externally rotated humerus, and you don't, because of just what's happening with the scapula. So it's quite interesting. A lot of stuff you have to look at. But that's a good question.
Question about this picture. So if there wasn't an impingement, what would you see a little differently from this cadaver? If there wasn't an impingement?
If there,
Right.
this
Yeah,
is
you would
just
see
showing
the
you.
bicipital groove more.
This is just showing you that there's a little shear in that bicipital groove. That's all it's showing you. But the transverse ligament can cause that to happen also, because it can become lax. And then the long head of the biceps could come in toward more medial, and it could be shearing with movement. And that's probably what you're seeing in this.
So the transverse ligament goes across?
Correct.
Okay.
All right, so we talked about the glenoid, we talked about the type of cartilage that's around the humerus itself. We talked about the glenoid. The glenoid seats the humerus and makes it more stable in the glenoid cavity. The coracoid process the scapula itself, right? So we know all about this. Avascular necrosis. So if somebody's, avascular necrosis means, what's avascular? Without blood, right? Without blood supply. Necrosis is death. So you can have avascular necrosis, and you may see avascular necrosis. One of the things you may see, it's tissue death. So the head of the humerus starts to die. And you may see this with a lot of corticosteroid injections. So if you have an injection, if you've gotten any injections in your tendons, any more than 3 or 4 starts to break down the tendon. So and this may be a pathology though. Somebody who has avascular necrosis may be secondary to some kind of pathology. Okay? So be careful when you're working with somebody who's had a lot of steroids and they're coming in with shoulder problems, knee problems, etc. Okay? So this can lead to tissue death of the bone itself and require that person to have a replacement. All right, again, just dermatomes. So I know some of you have done dermatomal and myotomal dances already. So what did we say? C4 is here, right? C5 is here, C6 is here. Joe loves to show you where C7 is. C8, T1, T2, right? So for the upper extremity, I expect you to know the dermatomes, and probably for the first quiz, I might ask you, draw the dermatomes of the upper extremity. Myotomes associated with that, guys, are what? From last class. It's just a review. What are the myotomes for C4? What muscles do I test, Andrew, for C4? C4, anybody? Trap, upper trap. C5? C5, delt. C6, biceps wrist extension. C7,
Wrist drop.
triceps wrist flexion. C8, finger flexion, so thumb extension. T1, finger abduction. What reflexes do I test for C5? C5 biceps, C6 brachioradialis, C7 triceps. Okay? Here we go. All right. C5, delta tuberosity, elbow flexion, biceps reflex. C6, lateral forearm, wrist extensors, brachioradialis. All right, I will tell you this. When we do a reflex for biceps, we hit the biceps tendon. Okay, we do hit the biceps tendon. Biceps tendon is located in the medial antecubital fossa. So we hit the biceps tendon. When we do C7, we hit the triceps tendon, which is right inserts into the olecranon. When we hit C6, the brachioradialis inserts into the radial, what's this called? What's it called? Stylar process. Stylar process, the radius. So a lot of people don't hit the tendon there because they're afraid to hit the bone, so they hit the muscle. Okay? But for your state board question, you would say proximal to the styloid process because that's where the tendon inserts. God bless. Okay? Just remember that because I know that was a state board question at one time. All right? So we usually hit the forearm here. Well, I don't, but you guys do. and, or you go down here, find the tendon and hit that, okay? So we have a biceps reflex, we have a triceps reflex, we have a brachioradialis reflex. The biceps reflex is C5, brachioradius reflex is C6, and the triceps reflex is C7. Okay. C8 and T1, no reflexes. Okay, glenohumeral arthritis doesn't look very good, does it? So, you see breakdown of the head of the humerus, breakdown of the glenoid. Rheumatoid versus osteo, I said rheumatoid is synovium, and osteo is cartilage. So you get a breakdown of the cartilage, you get inflammation, synovial inflammation. A lot else happens with rheumatoid arthritis we'll talk about. Does anybody know the difference between an ankylosis and an arthrodesis? No? Nobody knows? An ankylosis is something that fuses on its own, and an arthrodesis is when they do surgical fusion. So sometimes you get ankylosing with rheumatoid arthritis. The bones start to lose shape and they start to join into one another and they start to fuse. Yes?
Is rheumatoid arthritis considered genetic?
Is arthritis genetic?
No.
Rheumatoid. All right.
Rheumatoid arthritis, autoimmune? It's supposed to be, but I don't know, it depends. You know, like, I mean, they're coming out with so much stuff on it. They're looking for specific markers of it, but they do say that, you know, you're likely to have it if somebody in your family has had it. Yeah. But it's not necessarily like everybody's gonna have it, you know, like psoriatic arthritis. Some people have, or, you know, like any other things. Yeah.
Who's arthrodesis and who's the other one? Arthrodesis and what's the other one?
Is
Ankylosing.
osteoarthritis what?
No, ankylosing.
Ankylosing. Ankylosing is a self-fusion. Ankylosing is it fuses on its own, as opposed to arthrodesis, which is a surgical fusion.
That's the fusion between the two bones.
If what?
It's the fusion between the two bones.
Yes. Or it could be several. Most commonly you see, you know, there's ankylosing spondylitis. Which, I don't know, have you ever seen somebody with that? They start to fuse at the thoracic spine, the anterior bodies of the vertebrae start to fuse, and you see somebody start walking like this, and they actually can't get up because they've got self-fusion. So, sometimes they fuse you intentionally, especially if you have instability. So if you've got like rheumatoid arthritis and you've got a wrist that's all wonky and all over the place and you've got all kinds of ulnar drift, they may fuse you just for stabilization and for decreased pain. So they may do a surgical fusion.
And they're like entire plant.
Oh, yeah. Oh, yeah, you get an ulnar drift, you get, yeah, you get the metacarpal start to drift.
That's why he's like, wait, have you ever seen him like turn? He goes like,
Okay, so here's your glenohumeral arthritis in a cadaver.
that too.
Look at that head. That's a cadaver. Yeah, it looks flat, right?
He's a massive dude.
You imagine that would be very painful, right? Is it time?
It's 12:49.
Yeah, 12:49?
Oh, quick.
Okay, we'll come back to this, we'll start this on Monday, yeah.
Fun, Joe.
Last lecture you mentioned certain nerves for certain muscle, can you just throw those for
I mentioned what?
certain nerve entering the forearm for certain
Oh, okay, yeah, the radial nerve enters the forearm through the supinator. The median nerve enters the forearm through the two heads of the pronator teres. The ulnar nerve enters the forearm through the two heads of the flexor carpioneus. All right, you can come back to